Hello, and welcome to another Alberta Stoner production. My name is Yiming Huang, and I'm one of the Adult Critical Care Medicine Fellows here at the University of Alberta. In this presentation, we will be discussing some common pitfalls of point-of-care ultrasound. So when we consider the usage of point-of-care ultrasound, it's fair to say that POCUS has become a tool that we use routinely, if not daily, in clinical practice, and especially within our ICU. However, despite POCUS being so readily available, we all have varying degrees of expertise with image acquisition and interpretation. And so with this, it's important to emphasize that POCUS remains as one tool to help clinicians approach a patient, and it doesn't replace our history, exam, formal radiology, and above all, our clinical judgment. To further highlight our need to look at our patients holistically and recognize POCUS as a powerful but nonetheless additional data point in patient care, our recent literature also provides a warning towards the pitfalls of perhaps over-relying on POCUS. Some select studies are shown here. So in 2023, Jones and colleagues described variability in POCUS image acquisition and interpretation, even amongst expert operators. In 2022, Berg and colleagues described discrepancies between POCUS diagnosis in shock versus treatment. And in that same year, Duflay and colleagues also demonstrated discordant findings between POCUS echo and formal TTE, which even resulted in delayed or missed interventions. And so, with all that said, the purpose of this video is to address some common, everyday assessments with POCUS and outline potential pitfalls of each. Starting with the inferior vena cava. So we know that assessment of the IVC plays an important role in estimating our right atrial pressure, and by extension, our patient's volume status. As such, being able to correctly identify the IVC, as shown on the left, and differentiate it from the aorta on the right is crucial, and not uncommonly, this can be quite difficult. This figure outlines three key components of differentiating our two vessels. Firstly, we see the IVC passing directly into the right atrium. Secondly, we can also see the hepatic vein draining into the IVC. And thirdly, the IVC passing directly through liver tissue. These three findings would expectedly not be present for the aorta. In reality, an image as clear as this may not be possible, and so we will go through things in a bit more detail. When looking for the hepatic vein draining into the IVC, we may not be able to see it clearly on regular 2D imaging. Our color Doppler can assist with this. Make sure to switch the color Doppler Nyquist to low in order to improve sensitivity for picking up the vessel in color. In this clip, we can see directional flow in blue, demonstrating the hepatic vein as it drains into the IVC, thereby helping us localize our IVC. Pulse wave Doppler can also be used to achieve the same effect. By placing our pulse wave sampling gate within the vessel, we can trace a flow waveform, which thereby helps us confirm the vessel's identity as the hepatic vein. Note that this waveform can vary depending on the patient's clinical condition, and this is described further in detail in a different video. Color Doppler can also be used to identify the aorta. Here we see clear pulsatile flow moving away from the heart and towards the probe in red. Care should be taken when using this strategy, as the color directionality of flow is relative to the ultrasound probe, and therefore will change depending on the angle of insonation. As mentioned previously, and in our separate IVC video, the appearance of the IVC can be helpful in our volume assessment. However, take note that multiple clinical conditions can dramatically impact the appearance of the IVC, independent of the patient's volume status. We've listed some of these conditions here. As such, decisions for giving more volume resuscitation or diuresis must incorporate a global assessment, not just the IVC. Some examples here include comprehensive point-of-care echo, VEXIS, clinical examination, and markers of end organ perfusion like urine output. Next, we'll be moving on to talking about the pitfalls of assessing pericardial effusions. Pericardial effusions can appear in a number of different ways. They can be circumferential or regional, they can be uniformly anechoic, or contain blood, clots, purulence, septations, all these things that can increase the complexity of their appearance. Really, multiple cardiac views are needed to properly characterize pericardial effusions. One common pitfall of POCUS for pericardial effusions is differentiating between a pericardial effusion and a pleural effusion. Both can be extremely similar in appearance. This adds further importance towards characterizing the effusion in multiple views, including also scanning for pleural effusions at the costophrenic angles. When looking specifically at the heart, the descending aorta can serve as a clue towards differentiating between the two. Pericardial effusions track between the descending aorta and the myocardium, while pleural effusions will appear distal to the descending aorta. This relationship with the descending aorta is detailed in this figure. In an off-axis apical three-chamber view, we can see the effusion noted by the red stars. These are proximal to the heart itself in comparison to the descending aorta, which is noted in green. This is again shown in an off-axis apical four-chamber view. The effusion in red lies between the heart and the descending aorta in green. Conveniently enough, this figure also contains a pleural effusion shown in blue. Note that the pleural effusion is now distal to the descending aorta, and we can clearly see the pleural pericardial interface outlined by the black arrows. The lung tissue can also be seen, outlined in yellow. Applying these findings clinically, it is important to highlight that the volume of a pericardial effusion does not necessarily correlate to pressure, and that hemodynamically significant effusions, i.e. tamponade, results in pressure overload. Shown in the graph to the right, pericardial pressure is noted on the y-axis and pericardial volume on the x-axis. Line A outlines a rapidly accumulating effusion where a relatively smaller volume results in a dramatic rise in pressure and therefore tamponade. Alternatively, line B shows a slowly accumulating chronic effusion. Here, slow accumulation of fluid allows for greater compliance of the pericardial space and therefore much larger volumes before pressure rises to pathological levels. It is therefore important to recognize early indicators of hemodynamically significant pericardial effusions, which is arguably even more important than just the size of the effusion. As pressure builds within the pericardial sac, this pressure is exerted onto the chambers of the heart and acts as a compressing force. It is therefore logical that if the pressure is applied globally and circumferentially, the chamber with the lowest pressure would be seen to collapse first. This is the right atria, and specifically at the end of RV diastole. At this point, the RA has emptied and is in its lowest pressure state. This is clearly demonstrated in the clips to the right in apical and subcostal four-chamber views. Further details regarding echocardiographic manifestations of cardiac tamponade are discussed in our dedicated video separately. Bringing things back clinically, erroneous diagnosis of pericardial effusions or missing signs of early cardiac tamponade because of a relatively small appearing effusion can be dangerous, particularly if emergency procedures like pericardial centesis are undertaken or even deciding to diurese a patient who is actually developing tamponade. As we've been emphasizing throughout this video, POCUS findings must be integrated with clinical findings and advanced ultrasound techniques. Next, we'll move on to pitfalls of using POCUS to identify pneumothorax. When we employ ultrasound to assess pneumothorax, it should be emphasized that our findings are often rule-out tests, being highly sensitive. This is especially true for the finding that we are all probably most familiar with, lung sliding. Lung sliding is extremely sensitive, meaning when we do see lung sliding, pneumothorax is effectively ruled out. However, lung sliding is not specific, meaning if we see that the lung is not sliding, this does not necessarily mean there is a pneumothorax. When using ultrasound for assessment of pneumothorax, ideally we should be using all of the tools as listed above. The pitfall of relying only on lung sliding is outlined here. As seen in both clips, the lung is not sliding in two different locations. However, remember that visually, this represents a lack of movement between the pleural interfaces. Any condition which compromises this interface will cause the appearance of no movement, for example, like in pleurodesis. Similarly, if the lung area is not being ventilated, then pleural movement and sliding would also be absent. Examples here include proximal airway obstruction from a mucus plug or mass, or intubation into the left or right mainstem bronchi. Looking at techniques beyond lung sliding, remember that lung point, when present, is nearly 100% specific for pneumothorax. However, a pitfall here is when the lung point is misidentified and the transition point between sliding to no sliding is actually the interface between the lung and diaphragm or heart. This pitfall can occur if a limited field of view is employed, as shown in the clips here using the linear array probe, which limits our field of view. In these circumstances, switching to the phased array or curvilinear probe would provide a larger field of view and identification of other surrounding structures such as the heart or diaphragm. Lastly, to quickly touch on lung pulse, remember that the presence of lung pulse reflects transmission of cardiac activity through the pericardial and pleural interface, thus ruling against pneumothorax. A pitfall to be aware of is that small arteries within the chest wall may produce pulsations which mimic lung pulse. The application of color Doppler can identify these vessels if this is suspected. Moving on to our last common pitfall, we will be talking about lung hepatization. Lung hepatization refers to the pathologic alteration of lung tissue such that it sonographically resembles liver tissue. Commonly, this occurs with consolidation, but atelectasis can also produce a similar appearance. Common pitfalls here relate to probe and image orientation, where misplacement or misalignment of our image can lead to incorrect identification of the organs in question. This can therefore lead to procedural errors. Here, chest tubes have been misplaced into the liver. To avoid this pitfall, ensure correct and consistent probe marker orientation on both the probe itself and your image. The probe marker traditionally faces cranially on the patient and screen left on the image in the lung or abdominal preset. This produces the imaging clip shown here. The lung is to the left, effusion in the middle, and diaphragm and liver to the right. Dynamic air bronchograms can also help distinguish lung from liver and spleen. Dynamic air bronchograms are formed with a combination of dense consolidation but patent airways that allows for air transfer. The presence of consolidation enhances the tissue-air interface surrounding the airway and thereby produces a bright hyperechoic signal. As air moves in and out of these airways with respiration, this produces the dynamic effect that we see. This would not be present in the liver or spleen. Lastly, if further uncertainty between liver, spleen, and lung remains, a useful tactic may be to actually scan more caudally along the axillary line until the interface with the kidneys are identified. From there, the operator can move more cranially with greater confidence that the next interface superiorly represents lung and diaphragm. And to finish off, we will call back to our opening slide here, emphasizing the importance of integrating ultrasound into our complete clinical picture. Ultimately, recognizing and avoiding pitfalls in point-of-care ultrasound are crucial towards incorporating this tool as a part of excellent patient care. I'd like to thank the following individuals for their contributions to this presentation. Thank you all for watching this video. As always, for more informative and educational videos in all things related to ultrasound, please visit our website at albertasono.ca. Take care.